The 2017 direct primary care legislation in Wisconsin has resurfaced. We're going to remind you what we mean by direct primary care and then take you through the timeline of where we've been with legislation in Wisconsin and talk about where we are right now. Let's start with what do we mean by direct primary care. It's a type of concierge medicine model. Patients pay a flat fee for services from a primary care provider, usually a doctor visit, a physical, and there's a set fee for each of those services, and insurance is taken completely out of the picture. You set up an arrangement with your physician and you pay for those services either on a flat fee per service or on a flat monthly fee schedule, depending on the arrangement you have set up. It takes insurance completely out of that doctor-patient relationship, but it, again, doesn't cover everything. If you're in an emergency car accident and go to the emergency room, that might not be envisioned in this type of arrangement. So typically, folks that have worked with a direct primary care relationship with a physician have also had other types of insurance, most commonly catastrophic coverage. That's why what we're talking about with direct primary care. Direct primary care in Wisconsin developed as legislation. It included Medicaid in that earlier draft of that legislation. It proposed to authorize Medicaid payment for health services under direct primary care. This bill determining what direct primary care would look like and how it could or could not be regulated was a lot of discussion in the legislature. It passed the assembly, but then the session ended, so it went to a legislative study committee, and this is where they really talked it out. The study committee was directed to talk about everything from reviewing direct primary care as a delivery option itself, assessing the impact on overall healthcare delivery and health outcomes, recommending legislation, integrating it into Medicaid managed care or fee-for-service, the impact on the efficiency of Medicaid, and to do a direct primary care pilot in Medicaid. That's what they were supposed to discuss over the summer, and they did. Now, let's fast forward to early 2019, and legislation has now resurfaced. The same original authors are on the bill. It looks different than the last time because that discussion really helped parse out some of the more controversial elements of that, largely the Medicaid language. It is really difficult to do direct primary care in a Medicaid payer system where you might be responsible for a bill, but the way that Medicaid works is a public-private partnership with insurance. If you take insurance out of the picture with direct primary care, you've got a payment problem, and you can't bill the patient for it because of federal rules on balance billing. So it became this hot tangle of entitlement rules, of payment rules, and of liability, and they took that out of the last bill for this new bill. They took it out of that last language and they left it. They're still going to study it. The way that it's being proposed right now is to move forward with talking about direct primary care in Wisconsin and study what that could look like in Medicaid in the future. So no pilot program, just a little bit more study of what that could look like in Medicaid. And they're going to do that through what they call a working group. Now, the way that they want to envision it is direct primary care consumers would pay a monthly fee for primary health care services. That's what the new legislation envisions. The bill clarifies that it is not health insurance of any kind, which just means there is no Commissioner of Insurance oversight, which started to raise concerns within the healthcare industry and from some consumer advocates. Concerns about consumer protections, including financial responsibility. Would direct primary care arrangements become vehicles for unregulated insurance products? Would it be a way to start sliding other stuff in there under this direct payment relationship with doctors? It started raising questions from the insurance industry along those lines. Now, the consumer advocates are saying, well, you really do get what you pay for, and consumers might be confused. They're paying a monthly fee to their doctor. The only time consumers have been used to paying a monthly fee is when they were paying insurance premiums, and that came with essential health benefits. That came with the whole package. So if consumers are making monthly fees directly to providers, they need to know the limits on what is actually, quote unquote, covered. What are the services that is actually buying? And because it's typically a very efficient and cheap process, it's not covering a lot of services. So you get what you pay for, and you need to know what you're paying for. And typically the folks that use these services are the healthier patients. Maybe it's for preventative care or routine screens or immunizations, maybe a couple generic prescriptions or some basic lab services, but certainly not more of the care that would be required for someone with chronic health conditions or requiring a lot of therapy services or whatever that may look like. Few other concerns is this really is not a product for those with complex healthcare needs, and they would need to know that up front. We have to do a lot of educating to consumers if this were to become a thing to know if this is a product for them or not. And typically, like we said originally, people who use direct primary care also have other insurance plans. And because they tend to be more of that catastrophic variety, they tend to come with really high deductibles. So people could get stuck with surprise medical bills by having a direct primary care relationship, having services that exceed those covered services, and being surprised with the full cost of what that might look like, either through a high deductible plan or out of pocket. So the last concern is whether or not there's any incentive for doctors to take direct primary care patients at all. Are they going to just be cherry picking the healthiest people that are the lowest risk to them? Most physicians might find that quite appealing. We just want the healthy patients. And you start chipping away at services available to those that have pre-existing conditions, other healthcare conditions, or the more dramatic chronic illness. You can take a look at that new legislation in Wisconsin, what it looks like, and you can start reaching out to some of the representatives that are drafting this in the legislature and share your concerns. But you can also contact us, and we're at healthwatchwisconsin.org.